Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad you could join us. And if you're joining us, be sure to like and subscribe to the show. It's always good to have those subscribers. Hey, today we're going to be joined by experts Dr. Jason Hafron and Dr. Shilpa Gupta, as they're going to be exploring refining treatment strategies for advanced and metastatic urothelial carcinoma. This is a 1 AMA PRA Category 1 credit. I will warn you, though, this one's only good till the end of February 28th, 2026, in case you're watching this on demand later on. So if you want to get that credit, you're going to have to watch it and go on there this month. So take care of that. But anyway, glad to spend some time with you and good to bring you some of these CME credits. It's always a nice thing to have. So we're glad to be able to partner with my CME and present these things for you guys. So hold on, and here we go.
Module will cover refining treatment strategies for non-muscle invasive bladder cancer and muscle invasive bladder cancer. Let's get started. First, we'll start with non-muscle invasive bladder cancer. We know that non-muscle invasive cancer represents 75% of bladder cancers at diagnosis. There will be 62,000 new NMIBC cases in 2024, and 25% of those newly diagnosed cases are high risk. High risk patients, and this is where the unmet need comes in, have a 60 to 70% chance of recurrence with a 10 to 45% chance of progression to muscle invasive or metastatic disease within 5 years. And we know the patients that progress from non-muscle invasive to muscle invasive bladder cancer have a much poorer prognosis than those that present with muscle invasive bladder cancer up front. Bladder cancer staging is pretty well known. There's clinical versus pathologic staging. Clinical staging is based on the histologic findings from TRBTs. Pathological staging is surgical staging. It's determined by extent of disease after partial or radical cystectomy and pelvic lymph node assessment. I think what's key here is that reassessment, every time a patient reoccurs or has a new occurrence, they need to be restaged. They need to be risk stratified according to the AUA risk stratification. We have low risk, intermediate risk, and high risk. As you can see on the screen, low risk is low-grade solitary TA less than or equal to 3 centimeters upon lap. Intermediate risk is recurrence within 1 year, low-grade TA. Solitary low-grade TA greater than 3 centimeters, low-grade TA multifocal, high-grade TA less than or equal to 3 centimeters, and low-grade T1, which we never see. High risk is high-grade T1, TA, and CIS, any variant histology, any lymphovascular invasion, or any prostatic urethral involvement. The key here is that the risk stratification not only has to be done every time a patient has a occurrence or a reoccurrence, is that from low risk to high risk, you see the risk of recurrence increases from less than 30% in the low risk up to 80% in the high risk, and the risk of progression in the low risk is up to 5%. But when you get into the high risk patients, that risk of progression can go up to 50%. Here are the current NCCN guidelines for non-muscle invasive bladder cancer management per risk group, and this is why risk categorization is so critical, because management is based on their risk. Low risk patients is pretty straightforward. Those patients stay on surveillance. Intermediate risk is pretty straightforward today, as those patients receive intravesical therapy for 1 year or can go on surveillance. And then the high risk patients, all those patients should receive BCG therapy, induction BCG with probable maintenance, and then they can be divided into BCG naive versus BCG unresponsive. If you look at the BCG naive, the NCCN breaks them down from very high risk to not very high risk, and the high risk patients are the ones that have, lymphovascular invasion, the variant histology, sarcomatoid, plasmacytoid, micropapillary disease. Those patients should go for probably immediate cystectomy. That's what's preferred. Or if they're not candidates for cystectomy, or you don't feel it's appropriate, they can go for induction BCG. But the typical patient with high risk disease, TA, T1, CIS, with no lymphovascular invasion, no prostatic urethral involvement, no variant histologies, those patients should go for BCG induction. Obviously, you can offer them cystectomy, but most of those patients will probably go for BCG. The area that we've seen the most change in the last year or two is the BCG unresponsive. That's what I'm going to talk about a lot today. And that the options for treatment right now, the current standard of care or preferred treatment option is for cystectomy, but you can also offer an intravesical chemotherapy, pembrolizumab, nadofaragene, or Antikva for select patients. But we'll talk about that more, about the BCG unresponsive. Like I said in the slide, radical cystectomy is still the mainstay for treatment in certain situations for high-risk non-muscle invasive bladder cancer. It's recommended for high-grade T1 disease with CIS, lymphovascular invasion, or variant histology. And it's a first-line option for BCG unresponsive, high-risk non-muscle invasive bladder cancer. Cystectomy is a great option. It performs well. Recurrence-free survival averages, based on published literature, 74 to 89%. The downside of cystectomy is it's an invasive operation, requires an extended hospital stay, and it does have a high complication rate. 30-day complication rate is about 39%, with a mortality rate of 2.1%. So according to guidelines, cystectomy is a great option. Reality is most patients don't want to do it. A lot of urologists don't prefer to do it, and people are looking for alternative options, is what I will talk to you about today. The first option is BCG therapy. BCG has been around for over 40 years. It was developed in the 1920s and applied in urology in the 1980s by Dr. Martinez in Canada. And basically, for high risk and intermediate risk, you get an induction course, which is 6 BCGs. There's currently only one FDA-approved strain. It's called TICE. It's manufactured by a single supplier, which has led to a lot of problems over the last few years. There is significant BCG shortages around the country, which has led to reduced maintenance schedules, dose adjustments, and alternative strategies. So BCG has been very effective. And if you look at the numbers for BCG, here's contemporary BCG effectiveness. You can see it works pretty well. It's not perfect. If you look at AUA high risk, 5-year recurrence-free survival, 71%. High-grade Ta/T1 is about 75%. CIS 5-year goes down to 66%. And Ta/T1 CIS is 67%. And then cancer-free survival, you can see in the table. So it works well. It has decent numbers. But what I'm going to highlight in the coming slides is that there is a significant amount of innovation going on, and that BCG, when it does not work, there's a lot of great opportunities or different therapies that we can offer our patients. So when we think of BCG failure, there's 2 concepts that you have to keep in mind. One is the patient has to qualify that they have to have recurrent disease, and I'll go through that. And then they have had to have received adequate BCG. A lot of these terms were developed by the FDA. They were made to study these new drugs. The reality is that we as urologists have to learn about these terms, apply these terms, because in order to use these therapies, the payers require documentation that the patient truly has recurrent disease, and they will require documentation that the patient has received adequate BCG. So what is adequate BCG? Again, it's a term developed by the FDA to study these drugs, but adequate BCG is that what we call the 5+2 rule. And basically, they've had to have received 5 out of 6 of their inductions plus 2 out of 3 of their maintenance to have received adequate BCG. They could have also received 5 out of 6 of their induction and 2 out of 6 of their second induction. Essentially, they've had to have received 7 treatments of BCG to say that that patient actually has adequate BCG. So that's one part of defining who these patients are. The second part is they have to be unresponsive or recurrent disease. And if you look at the panel over on the right, these are the definitions. They're a little wonky. They're a little not straightforward, but these are what you have to use when looking and evaluating these patients. Otherwise, you're going to have trouble identifying who qualifies for therapy, and you're going to struggle with getting these therapies reimbursed. So when we say a patient has persistent or recurrent CIS plus or minus TA or T1 disease within 12 months of adequate BCG, that's BCG unresponsive disease. They also can have recurrent high-grade TA or T1 disease within 6 months of completion of adequate BCG. That's an early relapse. Or, which is interesting, they can have T1 high-grade disease at first evaluation after adequate induction. That's BCG. So there's really like 3 different ways that a patient can have BCG unresponsive disease as long as they received adequate BCG as described before. Now let's hear from Josephine about her experience with BCG unresponsive non-muscle invasive bladder.
I received my diagnosis when I noticed blood in my urination and often frequent urination. So yeah, I had to go see my primary physician for tests, run some certain tests, and a couple of tests several times before I get to receive my diagnosis. It was a shared decision with my team because they run me through several options, therapies. Of course, they run me through several options and therapies, specifically BCG. I underwent multiple cycles of BCG. Yes, of course, but at some point, new tumors got discovered. So at that point, I knew that BCG was not an option anymore for me. And to be sincere with myself, it was very, very heartbreaking because all I wanted was just to feel very much better. When I realized BCG was no longer an option for me, my care team did, bring out alternative. Of course, they did bring out alternative options, therapies for me specifically. They did bring out alternative therapies for me to. There were clinical trials, of course, that I could go for, and yes, they did. They went through the whole journey with me. Clinical trials, like I said at that time, were brought out for me as an option, specifically immunotherapy. Yes. So like I said, I took my time to, get to choose. I took my time to know which one was safer for my health. Yes, as much as I'm going through this, I still want to live, of course. So I took my time to know which one was safer for my health and which one I believe strongly I would survive.
So I don't know about you, Dr. Gupta, but unfortunately, this story I see commonly almost on an everyday, almost every day, is patients that fail BCG. You're looking at the literature, looking at the data. BCG is effective, but it has a high recurrence rate. It does have a high progression rate as well. And I think if I was counseling Josephine, and we're kind of getting spoiled with riches, is there's so many new drugs that are available to that there's so many opportunities to offer her. And I with these patients, I try to be positive because looking starting in 2020 with pembrolizumab, 24 we got 2 new intravesical agents, we got more coming. There's just so many new therapies that are effective, that have nice CR rates, and that you look at their adverse event profile, they're very well tolerated.
It's very important to have all these options available, right? I mean, BCG has been the gold standard, but what next? And now we have a plethora of agents, and we are in a situation where what to use first, and each drug has a different mechanism of action and side effect profile. And I think the time is the current era is where medical oncologists have to work so closely with urologists. Back in the day, we didn't even know what BCG unresponsive disease is, but now we are kind of embedded in all these trials and multimodality care. So it's really great to see how the field is moving forward.
No, I totally agree, because if you think about it, most of superficial bladder cancer was handled by the urologist for the last 40 years. But looking at the new literature, looking at what's being studied and what's coming, you're going to have to work very closely with your oncologist. These patients require a lot of visits. They require their surveillance cystoscopy. They may be still on maintenance BCG. They might be on an IO. But I think of that relationship with the oncologist, or if you're in a large group practice and you can offer it at your own practice, it's an advantage too. But it's very exciting, and the also interesting thing is that when you look at the patient perspective, with bladder cancer, and you compare the patient perspective and their quality of life between non-muscle invasive and muscle invasive bladder cancer, the patients with non-muscle invasive bladder cancer have a much poorer quality of life. These therapies can be very toxic. They're coming to the office a lot. There's a lot of therapeutic burden associated with non-muscle invasive bladder cancer, even less with muscle invasive, localized disease. So I think that patient perspective is really critical when choosing therapies and deciding what to do next.
Yeah, I think the treatment burden and the financial burden with the NMIBC is like billions of dollars just in the US, the lifelong monitoring. So totally agree.
Yeah, that's a great point, because non-muscle invasive bladder cancer is probably the most expensive cancer to treat in the US right now.
Yeah.
So it's important to keep in mind. Getting back to post-BCG treatment recurrence, this is a great diagram to help you understand who qualifies. I like to use this diagram and work from the bottom up, and then you can use these terms. It kind of makes all these terms make sense that we're forced to use in identifying and staging these patients. As far as treatments, I think our new one, I'm going to go through some of these treatments. This is Antikva. I'm not going to try to say that the generic name for Antikva, but Antikva is a combination with BCG. It was approved last year for BCG unresponsive NMIBC. It's patients with CIS with or without papillary tumors. It's an alternative to radical cystectomy. I think the key is that you have to initially offer them a cystectomy. If a patient refuses or is ineligible, you need to document that in the chart. It's an intravesical administration given much similar to BCG. The cool thing is the mechanism of action. It's a IL-15 receptor agonist, and it basically recruits T cells, NK, natural killer cells, CD8, and augments the BCG response. What's interesting, it doesn't augment it with worse adverse events. It kind of uses the immune system to improve BCG. And you can see its response. Its CR rate is 71%. Duration is very good at 26.6 months. And after 24 months in patients with a CR, the probability of avoiding cystectomy is 89.2%. Disease-specific survival is 100%. Again, most adverse events were grade 1 or 2. It's very well tolerated. And it's Antikva is the name of this new drug. The next drug that also came out last year was nadofaragene. Nado was approved in 2024. Again, similar indication, BCG unresponsive plus or minus papillary. Again, an alternative to radical cystectomy. It's a little bit administered differently. It's administered quarterly, so it's administered every 3 months. Mechanism of action is very exciting, very cool. It uses a non-replicating virus vector to deliver interferon gene into bladder cells, and the bladder cells actually secrete interferon. Performance of nadofaragene looks very good. Patients' complete response is 53.4% at 3 months, 72% for high-grade Ta/T1, and all patients' a complete response at 3 months is 59.6%. The other drug that's been around for a little bit is pembrolizumab. It was approved in 2020. It's again for BCG unresponsive, non-muscle invasive. CIS plus or minus papillary, alternative to radical cystectomy. But as we know, it's as pembrolizumab is intravenous administration. We know the mechanism. It works off PD-1 and PD-L1 and enhancing T cell response. And here, the trial that led to its approval was KEYNOTE-057. It's 101 patients with high-grade CIS. Their CR rate was 41%. Duration of CR was 16.2. 46% of initial responders had a CR lasting greater than or equal to 12 months at data cutoff. So a lot of new drugs, and here's kind of like a summary slide that explains the new drugs. I think this really, when you put them side by side, you see the good and the bad of each of them. What I like to look at when I'm looking at this slide is I look at the CR rate at 12 months, and you can just, pan across the table and you can see there's differences. Also on this table is gemcitabine plus docetaxel. This was done at a multi-institution retrospective, so not in that prospective FDA regulated trial, but still there is an argument for gemcitabine and docetaxel in the space. And then you can look at the safety and tolerability. The intravesical agents have a much lower discontinuation rate, where pembrolizumab, the systemic, had an 11% discontinuation rate for systemic therapy. But I think using these tables, really mapping it out, is very helpful to understand, the pluses and minuses of each of these therapies. And here's another way to look at it. We basically have 2 approved intravesical agents for CIS refractory, NATO and Antigva. We have an approved systemic therapy called pembrolizumab. And then obviously first-line or recommended therapy is radical cystectomy. What also we have coming, hopefully this year or soon, we don't know for sure, is we have 2 new intravesical agents, which I will highlight now. The first one is TAR-200. It's gemcitabine intravesical releasing system. A lot of people call this the pretzel. It's like a small, rubber tube that you implant into the bladder, and then it kind of just magically forms this pretzel, and then it gives this low dose gemcitabine release. The device is as small as a quarter, and it sits in the patient's bladder. It's very well tolerated. If you look at these patients, they have to have this, it stays in for about 3 weeks, and it will stay in for 24 weeks. And then there will be a maintenance therapy for 3 months after that. Here's the most recent presentation of the pretzel. There's Sunrise 1. Just look at the pink bar in the middle. Sunrise, pretzel looks really good in clinical trials. Its CR rate is 83.5%. Its estimated CR rate is 57.4 months, or 57.4% at 12 months. So has good durability. So the pretzel in initial studies is performing well. Probably will be FDA approved later this year. These other cohorts have been just basically aborted because TAR-200 or pretzel monotherapy has been so successful in clinical trials. The other exciting new agent is cretostimogene grenadenorepvec, and that's oncolytic immunotherapy. Creto, as it's commonly called, again, another mouthful to say, has a dual action or dual lethality. It's basically oncolytic immunotherapy that goes into the cell through this Coxsackie adenovirus receptor. It preferentially replicates or kills cells that have EB2RF mutations. And then those, once it's in those cells, it also has a second mode of action where it expresses GM-CSF, so that when the cells die, that the immune response is enhanced with the expression of GM-CSF. So dual mechanism of action, dual lethality. The mechanism of action is important because that GM-CSF leads to a nice durability response in initial trials. Here's the data that was presented at the SUO recently, Bond 003. Their CR rate was 74.5% with plausible response between 65.4 and 82.4. 12-month CR rate was 46%. 97.3% were progression-free from muscle-invasive bladder cancer at 12 months. 90% cystectomy-free at 12 months. And then CR was consistent across all patient subgroups, and all the CRs were essentially confirmed with central pathology. So another intravesical agent that's very exciting. Another exciting area that's very hot in research is using checkpoint inhibitors plus BCG. There is a perceived synergistic approach, be using the combination of both. Some early data, the rationale is shown that non-muscle invasive patients showed increased PD-L1 expression post BCG, making PD-L1 inhibitors a viable strategy. And then when BCG upregulates PD-L1 expression, the theory is blocking PD-L1 may enhance BCG immune stimulating effect by reducing T-cell inhibition. Some early studies by Wang et al. Showed that it did reduce tumor burden and improve survival. So what's exciting is there's 4 major trials that have all completed enrollment. One of the trials, CREST, has had a top-line result. But looking at the combination of BCG plus IO, they're essentially all designed. The trials are very similar. There's a variance whether they use the IO in maintenance or not, or just an induction. But all the IOs are involved: avelumab, atezolizumab, sanslimab, which is a sub-Q IO, which is very exciting. And then you also have pembrolizumab plus BCG. So if these trials are positive, 1 out of 4 is positive already. This can have a significant impact on standard of care, where the combination of BCG plus IO would be strongly considered. The question is, will it be worth it? It's a risk-benefit analysis. The potential benefits are reduced recurrence risk. Current risk of recurrence is 50%. Decreased risk of progression. Can we lower it from the 20-40%? The risks are obvious. IOs are not benign therapy. They have immune-related adverse events, endocrinopathies, all of those things colitis, pneumonitis, all the things that we've seen already. So as urologists and as the data comes through, we need to evaluate and see, the true value of combination IO with BCG, but more to come on this. I want to switch gears and talk about not only is non-muscle invasive bladder cancer exploding with new therapies, but muscle invasive bladder cancer over the last couple of years has also had some very significant practice-changing trials come out. Management of MIBC historically has been neoadjuvant cisplatin-based chemotherapy. Cis-eligible patients, this is how we've been treating them for the last 40 years. You can use gem-cisplatin or dose-dense MVAC. Both are acceptable options. And then typically we would take them for cystectomy and watch them. The problem is about 50% of these patients recur within 3 years of surgical resection. What you may or may not be aware of, there was 2 major phase 3 adjuvant immunocheckpoint inhibitor trials. So in these patients, they all received standardized neoadjuvant gem-cis chemotherapy, and then the high-risk patients underwent immunotherapy with nivolumab or pembrolizumab as adjuvant. And I'm going to show you the data. The endpoints in these trials were disease-free survival with adjuvant IO therapy. The first was Checkmate 274. It was adjuvant nivolumab. It was a 1-to-1 randomization in high-risk patients following cystectomy. They either got nivolumab or placebo, and they were treated for up to 1 year of adjuvant IO. Here's the data in the intended to treat population. Hazard ratio was significant at 0.71. The enriched PDL1 greater than or equal to 1% population hazard ratio was 0.52. So positive for disease-free survival in the adjuvant setting. The other trial that was conducted was the Ambassador Alliance trial, and this looked at adjuvant pembrolizumab, and this was given again 1 year, very similar trial design. Patients either got pembro or were observed. Dual primary endpoint was disease-free survival versus overall survival. And what's interesting in this patient population is that in the Alliance trial, disease-free survival was positive. Hazard ratio was 0.69, which was significant. In the interim overall survival rate, we haven't really achieved a complete response, or it's to be determined. Hazard ratio is 0.884, but you can see, 0.98, but not significant. We'll just have to follow further analysis to see how the overall survival is affected. The newest trial, which just came out last year, is that what if we added a PDL1 with neoadjuvant chemotherapy and as adjuvant? And this looked at gem-cisplatin plus durvalumab. Patients went for cystectomy, and then they received adjuvant durvalumab. And what's interesting, and here's the trial design, which you see. So they got neoadjuvant IO, adjuvant IO, durvalumab, and compared to standard of care, which was gem-cis versus observation. And here's the most recent data. The trial was called Niagara, and it was positive. And we saw, improvement in event-free survival. We saw improvement in overall survival. And what's interesting is the neoadjuvant durvalumab did not delay surgery or impact the ability of the patient to undergo a radical cystectomy. It was tolerable. There was no new safety signals. Most AEs were manageable, and grade 3 or 4 events were similar in both treatment arms, which is interesting. Here's some more data that you can look at from Niagara, specific to the perioperative and cis-eligible muscle-invasive bladder cancer. In the durvalumab arm, the risk of metastasis-free survival was reduced by 33%, and the risk of disease-specific survival event was reduced by 31%. Perioperative durvalumab plus neoadjuvant chemotherapy improved event-free survival and overall survival in both the pathologic complete response and non-pathologic complete response groups in an exploratory analysis. Immune-mediated adverse events were mostly low grade. So here's a very provocative study that's showing that the IO durvalumab in the neoadjuvant as well as adjuvant setting in combination with neoadjuvant chemotherapy is effective. As a urologist, someone who's performing cystectomy, someone who's performing and treating these patients, you may or may not be giving these types of therapies, but as the advocate for your patient and for this disease, it's important that you discuss this with your community oncology partner.
For NMIBC and MIBC, and now we'll move forward to advanced and metastatic urothelial cancer, where there's a lot of excitement going on now with a lot of new drugs out there. So I'll first start with the standard of care for the frontline treatment for metastatic disease. You know, the landmark would be the EV302 study. Before that, what did we do? And now what do we do? Because this has been a game changer for our patients and the community in general. So I'll say that, you know, before we saw the approval of enfortumab, vedotin, and pembrolizumab, this is how we were treating metastatic disease. If patients were platinum eligible, whether cisplatin or carboplatin, we were giving them chemotherapy, whether gemcis or gemcarbo. If they progressed, then there were several immunotherapy agents approved, but for level 1 evidence, we were using pembrolizumab because that's the only one with the phase 3 survival data. But if avelumab and nivolumab were available in places where pembro is not available, let's say outside the US, many places, those were reasonable options too because they were also approved. And if patients were not progressing on the chemotherapy, we used avelumab maintenance based on the Javelin Bladder 100 trial that showed that moving treatment early when patients are benefiting from it after platinums, instead of just watching them, improve survival. And if after that patients progressed, we had the option of enfortumab vedotin as a monotherapy, which improved survival. We also had urologically for patients whose tumors expressed FGFR3. And in the US only, we had another antibody drug conjugate targeting TROP2 called sacituzumab govitecan. This accelerated approval was based on a single-arm phase 2 study. And now we know that this has been withdrawn from the market because it did not show any improvement in efficacy over salvage chemotherapy in the randomized phase 3 trial. That's why I put it in the red there. And, you know, in the US, we were fortunate that we had EV Pembro approved for patients with cisplatin ineligibility criteria, and they could get EV Pembro. If they progressed, then sacituzumab, erdafitinib, and platinums were options. In the truly platinum ineligible patients, which we had actually defined a few years ago, that is, they're very frail, creatinine clearance less than 30, you know, bad peripheral neuropathy, heart problems, etc. They could get single agent pembrolizumab up front, and if they progress, could get erdafitinib of EV. Now, these patients, you know, usually are so frail. So if somebody is so frail that we can't even give them carboplatin, those patients certainly are not candidates for enfortumab. And these are the frontline trials that have been completed in metastatic disease. 4 out of 5 have been reported. So one is the pivotal EV302 trial, which I will discuss later on. Then we have the Checkmate 901 trial, the Keynote 361, IMvigor 130, and NILE. So let me go over the IMvigor 130. This was the trial that looked at, is adding chemotherapy to immunotherapy better than just chemotherapy? Unfortunately, it did not show any benefit in overall survival. There was only a modest PFS benefit. So overall, it was a negative trial. Atezolizumab has actually been withdrawn from the US market. So this had another parallel trial, Keynote 361, where again the same question was asked if pembro and chemo was better than chemo alone. Chemo was, platinum based. In both these trials, we also had cisplatin ineligible patients where single agent immunotherapy was compared to gem-carbo. And surprisingly, it did not fare better. Keynote 361 was a flat out negative trial too, no OS or PFS advantage. So in these two trials, did not really move the treatment advances. But we recently saw in Checkmate 901, only for the cisplatin eligible patients, when they received gem-cis nivolumab, that met the overall survival, progression-free survival benefit compared to just gem-cis. Now, I have to mention here that the control arm, majority of patients did not get maintenance avelumab. Same for EV302, where enfortumab, vedotin, pembrolizumab was compared to just chemotherapy. The middle arm was dropped. We saw at least 30% patients did get maintenance avelumab in the control arm because, by the time the study was half done, that's when avelumab got approved. The only trial we are awaiting data is the Nile trial, which is looking at durvalumab and chemotherapy versus durvalumab plus tremelimumab and chemotherapy versus just chemotherapy. So that is the here we see. And there's one other trial actually which looked at durvalumab tremi, was the Danube trial, which was also a negative trial. So looking at the EV302 trial, this is the pivotal trial that has really changed our practice patterns around the world. So patients were locally advanced urothelial cancer, eligible for platinum, EV, and pembrolizumab. Obviously, checkpoint naive and platinums could have been used in localized setting, as in the adjuvant or neoadjuvant portion, as long as it was above 12 months over prior to enrollment. 886 patient trial, patients received enfortumab, which is an antibody drug conjugate targeting Nectin-4 with an MMAE, and pembrolizumab was given along with it. Day 1, day 8, every Q3 weeks was EV, and pembro was once every 3 weeks. There was an end date for pembro at 35 cycles or 2 years. There was no really maximum treatments outlined for EV at the time. And so it continued as long as patients could tolerate, which I'll just discuss. It's not that easy to keep giving that drug. And median number of cycles is actually around 9. Chemotherapy, gem-cis or gem-carbo, was for a maximum of 6 cycles. Like I said before, avelumab was not available at the time, but when it did become available, it was allowed for patients if they wanted it or needed it as standard of care, but not mandated per protocol. Dual primary endpoints for PFS by blinded independent review and overall survival. And these were the extraordinary curves that now we saw follow-up data. The initial curves showed really over 55% reduction in the primary endpoints overall. But here you see that at 2 years, the benefit was well maintained, and the curves continue to remain separated. So we see that at 2 years, the progression-free survival benefit 37.1% with EV pembro versus 12.6% with chemo, and the reduction in death still reduced by 50%. And if we had to go by the initial trial EV103 in cisplatin ineligible patients, which really set the stage forward for EV pembro, the data that we saw at 5 years out still holds true. So if that is of any reassurance, I think this is what we will continue to see with this even in EV302. So this was very reassuring data. So talking about the toxicities of EV302 with the different agents, chemotoxicities were pretty expected, mainly myelosuppression, which we are used to treating with cisplatin, carboplatin for decades. EV pembro does have unique toxicities. The key ones we need to really worry about are peripheral neuropathy, which we usually see in over 50% patients, and this can get quite debilitating if we don't dose reduce or dose modify or stop the treatment with EV. And rash is another significant toxicity which can happen in about 1/3 of patients and sometimes become life-threatening. So really important to be very good at history taking, because patients many times underreport their symptoms when they're on EV Pembro because they're deriving a benefit. It's all about, reassuring the patient that even if we stop the drug, the benefit continues. And if we continue the EV treatment through peripheral neuropathy, they can get really bad neuropathy. And it's not just peripheral neuropathy, they can get motor neuropathy. Many times, you ask the patients, they refuse any side effects, but when you make them walk, they're like wobbling. So always good to take that history, make the patient walk, do a neuro grip test, do a skin exam, just to make sure we're not missing anything. Blood sugars can get elevated on this. Patients can get catastrophic diabetes. So, there's a cutoff of not treating over a certain blood sugar level. So always make sure to check that. And this was the subgroup analysis that was presented here at ASCO GU just last week, that regardless of cisplatin eligibility or cisplatin ineligibility, patients derive benefit from EV Pembro. Now you see that, the curves for cisplatin ineligible are separated a little bit more. That's also because carboplatin is not as effective as cisplatin, and that underperforms. And PD-L1 really has no value. We've already shown in the past that level of nectin expression also does not matter. So there is really no utility of checking any biomarkers for prescribing this. And the key here is, liver metastasis is always a sign of bad prognosis, but in unique activity of EV is seen when added to Pembro, and single agent immunotherapy is also not effective in liver mets, but with this combination, we see that really patients with visceral metastases, especially even in the liver, do extremely well. And also lymph node metastases, patients do well, no matter what treatment they get. So they, regardless of site of metastases, they benefit from this combination. Checkmate 901, like I mentioned, was this cohort was only cisplatin eligible. They get standard doses of cisplatin and nivolumab first, every 3 weeks. Then maintenance nivolumab every 4 weeks. Have to highlight here that only 19% patients in the control arm got any immunotherapy. So, the control arm was not super optimal. And the overall survival here, as you can see, the numerically, it's not, even if you don't do cross-trial comparison, it's positive. Numerically, it's like 18.9 months in the chemo arm versus 21.7 months in the combination arm. And PFS also, it's more about the durability there. Really, the median PFS was not numerically much different, but you can see the curve separating out. Toxicities were pretty as expected from chemo and immunotherapy, nothing new there. And this is something, both these regimens are approved in the US, but EV Pembro is the frontline preferred category 1, and nivolumab gemcis is the other option. For example, if somebody, I really can't think of a situation where in the US we would not be able to give EV Pembro, but be able to give nivo gemcis, because if somebody has really bad neuropathy, then you can't give them cisplatin anyway. So I think for other countries where EV Pembro may not have access or affordability issues, then I think that's a possibility to use that instead of EV Pembro. Now, we do what we do all for the patients. So I think this is really great. We have a patient called Osman who will share his experience with metastatic disease.
It all began when I started feeling some sort of pelvic pain, weight loss. I had urine. When each time I urinate, I feel some blood in it. I had some fatigue. I easily get exhausted and all of that. I had some sort of chest pain, and so I had to go to the hospital, and I saw the doctor, and there was this urinalysis that was done for me, like my urine sample were taken and some sort of test was done. And I think at that point in time, it was disclosed to me that I had urothelial carcinoma, like cancer. Yeah. The doctor at some point talked about spread, which is what you call metastasis. Am I correct? So there was this option of me having immunotherapy because he tried to explain that since it is still the early stage of it, that I need to have some sort of immunotherapy, and it will help boost my immune system so I can actually be able to fight against the cancerous cells. So that was the first line of action I could recall. I also feel some sort of reactions having some metallic tests in my mouth because the doctor actually explained that some of the drugs I have could react that way. I felt weak. I did series of chest x-rays in order to monitor my lungs to see if there was a possibility of spread areas to my abdomen, my chest, and other parts. So in the process of having those x-rays, MRI scans and CTs, I felt weak. I felt dehydrated, and I felt dizzy, and I felt some weaknesses within some joints in my chest region.
So this was really interesting to hear from Osman about his experience, about his diagnosis, and how his experience was on immunotherapy with some of the toxicities. You know, for the most part, immunotherapy is very well tolerated, but it can lead to pretty much any side effect from head to toe. So it's very, very important to have that conversation with the patients up front as to what to watch out for and not to ignore any symptoms, because sometimes the side effects are not as apparent as we have with chemo. They could be very vague but serious. And I wonder, Jason, what are your thoughts with immunotherapy also, you know, in the localized setting and in large urothelial urology practices?
Yeah, I think I agree with you with you, Shilpa. I think the key is that you got to identify the adverse events early, and you know you got to ask the questions. Are you moving your, any problems with your bowels, any shortness of breath? You know, if you don't ask, sometimes you'll miss that opportunity to to identify it, treat it early. I think most of the time, if you miss it or you don't address it early, can lead to much more serious complications down the road. So I think it's very important to, obviously, counsel them on what to expect or what could happen. And if you do have any of these symptoms, to call your office or your staff immediately so that we can jump on these events.
Absolutely, totally agree. And I also tell my patients, if they are going to emergency room for something, to show them this is what I'm on, to make sure they're not missing out on immunotherapy related adverse events.
Right. And most of these events, when they're caught early, patients do very well. If a steroid's required, recovery is usually adequate, but it's that communication is really critical with your patient.
Now, these are the NCCN guidelines, which, as we can see, both for cisplatin eligible and cisplatin ineligible patients, Category 1 preferred regimen is EV Pembro. Now, the cisplatin eligibility is kind of a moot point with EV Pembro, but this is how we've always categorized frontline treatment and treatment in urothelial cancer in general. But we see that for cisplatin eligible patients, the other regimens are GemCis Category 1 also based on phase 3, and also followed by avelumab or combined with nivolumab upfront. So these are options that we can use. And for cisplatin ineligible, those who have really a strong contraindication to EV Pembro, you can use Gem Carbo followed by avelumab maintenance. So while we have all these exciting new trials setting the ADC IO combinations forward, there are a lot of questions about dosing, duration, and sequencing which remain unanswered. Like, for example, we don't know if we need to continue EV for a long time, because we see that not everybody can actually get that much EV because of the side effect profile. But the big question is, does everybody even need that much EV? And those questions, will be answered by some de-escalation trials. But the key message is that if patients are having even, the beginning of neuropathy, just take a break. And then if we have to restart after it gets better, do at a lower dose. Real world patients are always different from trial patients, and we really have to be very proactive about not getting to a point where these toxicities become debilitating. And now that, EV Pembro is the front line, where do the platinum stand? I think it's a very valid second line option. Even on the EV302 study, 30% patients ended up getting platinums and showed good activity. So we are going to see this platinums move to second line. And in the US, we also have HER2 directed antibody drug conjugate TDXD available for a blanket approval, tumor agnostic approval. So it's a good idea to look at IHC for patients who are progressing on standard therapies. And we also have the FGFR inhibitor, erdafitinib. So I would say that, in the EV302 era, the preferred treatment is EV Pembro. If patients progress, then use platinums. If they have FGFR alterations, that could be an option after the platinums. TDXD if they have HER2 positive at the rate of 3+. Platinum followed by avelumab and gemcis nivolumab are other alternative options. I think this is more applicable to the rest of the world, which unfortunately there's a lot of disparities in access to these novel drugs. And if they progress, then EV and erdafitinib are options. The truly platinum or EV ineligible patients, single agent pembrolizumab is an option. And then we have TDXD and erdafitinib also. For subsequent line therapies, as I mentioned in the paradigms, these are the regimens one can use depending on where they practice, what are the practice patterns. But sacituzumab govitecan has been withdrawn from the market. This is what sacituzumab govitecan initial study looked like. It was a phase 2, showed pretty promising activity at the time. And that's why the phase 3 was launched. And these patients were prior platinum and immunotherapy treated. And in this phase 3 trial, there was not only improved efficacy compared to vinflunine or docetaxel, but there were also more toxic deaths from neutropenia. So this was a negative study. This was the Destiny Pan-Tumor 2 phase 2 trial, tumor agnostic, looking at HER2 by the gastric cancer testing criteria, and patients who had 3+ expression of HER2 derived most benefit. Currently, it is approved for those patients now. Can we use it in 2+? That's not on the label, but we've seen in breast cancer, there's categories of HER2 low, HER2 ultra low. That's where our field could be headed, but we need more data. For erdafitinib, this is a targeted therapy for FGFR3 or FGFR2 alternating mutations or fusion. This was the initial trial, phase 2 trial of BLC 2001 in about 99 patients, which set the activity of this drug in patients with alterations. And in the phase 3 trial, there were 2 cohorts. In cohort 1, it was compared to standard of care chemo. And in cohort 2, the big question was, let's say somebody got platinums, but no immunotherapy. Should we give erdafitinib first or should we give pembrolizumab first? So that was the sequencing question, which was very nicely answered in this one study with 2 cohorts. So in the cohort 1, we clearly saw median overall survival benefit of about 4 months with erdafitinib, and it received full approval. In the cohort 2, we found that, using erdafitinib first was not better. So that was a negative cohort, which means that still use immunotherapy before using erdafitinib in select patients. So this is the treatment paradigm. Again, conclusions, EV Pembro is the preferred frontline therapy for patients with locally advanced metastatic urothelial cancer when available and accessible. Second line platinum is effective, about 30% response rates should be considered. Now, if after EV patients have significant neuropathy, you could do gem carbo instead of gemcis. Genomic testing is very important to look for FGFR2 and 3 alterations. Now, unless we check it, we won't find it. Same for HER2 testing by IHC. So if a patient is metastatic already, it's a good idea to start lining those tests up. And there's still an unmet need for novel drug development with newer ADCs and bicycle technology compounds. For example, we have the DVO1 study, which is looking at another ADC called dasatinib vedotin targeting HER2 versus platinum. Now, is platinum the adequate control arm now with EV pembro as the standard? It's not, but this study was started, before EV pembro got approved, and it's continuing in that regard. There's also novel drugs like the bicycle technology compound. There's Darbelo trial where it's targeting Nectin-4, but it's a unique technology. And so there's a lot of drugs in the frontline setting, although I will say that none of them are comparing against EV pembro. So once we have more data, we'll know where the field is headed. And at the end of the day, it's really great to have more options so we can offer what is the best regimen for the patient sitting in front of us.
Thank you, Dr. Gupta, for joining me today and engaging in such an insightful conversation. This was great. I would also like to thank Janssen Biotech, administered by Janssen Scientific Affairs, and Pfizer for their support of this and very important educational activity.
Oh, there you have it. So that was really a great review of what's coming, what's out there, what's new, what's going to be coming. I think it's amazing. I've fortunately been able to spend a lot of time in my career, my past 40 years, treating bladder cancer patients. And, I was around when BCG was still experimental. And I can remember patients with thiotepa, what a pain that was to administer, watching, blood counts and things that you had to monitor. And then this drug BCG came along, and suddenly people were coming back and not getting recurrent tumors. One of the things I learned early in my career too was patients that had recurrence, I always asked them, are you still smoking? The ones that continued to smoke tended to be the highest recurrences. Now, that's not evidence-based. That's my own observational, but I got a lot of people to quit smoking and a lot of them that didn't have recurrent tumors after that. So BCG is amazing. Really looking forward to that gemcitabine pretzel coming out. I don't know what your thoughts are on that, but I'll be looking for a speaker to talk about that when it's approved, because again, I'm glad I chose urology over oncology, because trying to remember all these chemotherapeutic, even be able to say the chemotherapeutic names is tough. Urology is a lot easier. So anyway, been great. As I mentioned in the show notes that unfortunately, if you looked at the website currently, the link that went to get the contact hours is incorrect. I put last week's link in there. I will correct it as soon as the show goes off the air so that nobody gets cut off when I'm making a change on the website. But it'll have the proper one. It'll be under the past episodes. For this episode, you just click it, get your CME link. You'll be all set. So with that, a couple of things here. Next week, we're going to have a great show coming up. Here's a little promo on that.
Sabuna certification is evolving. Are you up to date? Join Vic Senese as he sits down with Sabuna President Christy Krieg for an important conversation on the latest updates in certification. Whether you're working towards certification, renewing your credentials, or planning the next step in your urology nursing career, this episode delivers clear guidance, key timelines, and insider insights straight from Sabuna leadership. If certification matters to your practice or your future, you won't want to miss this update. Join us on February 14th at 9 a.m. Central Time to learn more.
And if certification doesn't matter to your practice, I don't know what should. I was certified very early on in my career and continued that throughout my career. It was kind of interesting because one of my urologists always would come and tell patients, oh yeah, this is my nurse, and he's certified just like I am. So he was proud of it. So I think it's really a great thing. And, I think it's having the president, Christy Krieg, join us to talk about more about it. If you have questions about certification, be sure to ask those in the comments. We'll see everybody on that next week. And hey, if you're just hanging around, if you're a patient and you listen to all this, God bless you. But if you're a patient and you're watching UroNurse, remember UroPatient comes on at 10:30. Today, we're going to talk about the problem that you can sometimes get with a long-term catheter, and that's stone formation around the catheter. And we'll talk a little bit about what you can do about that. So check that one out too. Otherwise, enjoy the rest of your week. Enjoy your day today. We got a nice sunny day, and it's almost feels warm out here in the Chicagoland area because we're in the 20s after being down around 0 most of the time. It's really a nice break. So enjoy your weather. We'll see everybody next week. And
so here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.